Hi, Jen.
Hi, Bethany.
What are we talking about today, Jen?
General anesthesia.
That's right. This is all you.
Woohoo.
This is another teaching.
You forgot your glasses.
I did forget my glasses, even though it's like cloudy out. I should have worn my glasses today. But before we get started on general anesthesia, I have to first throw out a shout out to our girlfriend, Michelle, who had her third baby via C-section, James, over the Memorial Day weekend.
Yay.
And I have to give myself a little pat on the back because I put this little care package together for her. And I had a green juice in there and a carrot ginger juice. And I could tell she was like, I'm probably not going to drink these. And the best text message I got back from her was, I'm telling you, this is the best secret ever. She's like, that carrot ginger drink saved me. As soon as I could start intaking fluid, she was like, that's exactly what I wanted.
And that
I
was
was like, I told you would love it.
that was for after, right? Because you got her the green
After.
joy juice maybe for the day before.
The night before, yeah. And then,
Okay.
and she went along, she got delayed, so she was hungry.
No, that
So
was
hungry.
awful.
So it's a good way for her to start replenishing herself without putting too much in her system too fast.
Good job, B. Good care
Thanks,
package. You're
thanks.
the queen of care packages. I
I
knew
do
you would
love
not
doing that.
disappoint.
Yeah. Okay, so you talk to us all about
Okay,
it.
so we're going to be talking about general anesthesia, which I do think is something that anyone who's planning a C-section should have some general understanding of. And so we're going to talk about the pros and the cons, why we as providers might choose general anesthesia, and if you can request general anesthesia as a patient, and also importantly, what to do if you want to avoid general anesthesia, which
Oh, yeah.
is, I kind of think we fall into two camps, right?
Mhm.
There are people who very much want to avoid general anesthesia at all costs, which I think is the majority of people having C-sections. We want to be awake ideally. And then there are those few people, but it's, I think, more than we realize, that are really thinking that they want to be put to sleep for their C-section. They're wondering, is that even possible? And how do they go about asking for that? So we're going to go through all of that today.
Can I tell you, I did not even think about that at all going into my C-sections. And when you brought this topic up to me, I was thinking, wow, that really should have been something I should have been prepared for, that I didn't prepare myself for at all. Wasn't even on my radar.
Right. And because it can happen. I mean, we just had a conversation with Rachel Sommerstein, our last maybe couple episodes ago, about how she was unexpectedly put to sleep under general anesthesia in the middle of her C-section. So that's something that could happen really to anyone. And so to have a basic understanding of that would be important. And then there are some people that from the very beginning, either we are saying that this is something we're recommending, or the patient can recommend or can advocate for themselves to be put to sleep if they want to. I'll go into that, my
Okay.
feelings on that.
I'm sure you
But-
will.
Yes. So let's first just talk about the pros and the cons. When we talked about spinal anesthesia in our second episode,
Oh my gosh, it feels so long ago, Jen.
millions and millions of years ago, I had said that more than 95% of C-sections in the United States are done under neuraxial anesthesia, which is either a spinal or an epidural, meaning you are numb, but you are awake, otherwise awake. And general anesthesia, when I'm speaking about general anesthesia, I really mean being completely put to sleep, unconscious, with a breathing tube in place, breathing for you. So this wouldn't be the same as getting sedating medications that might make you not remember or kind of drift off. This is really being put totally asleep under general anesthesia. And we do that with IV medications. And then once you're completely unconscious, then you always have to get a breathing tube for all pregnant women. So this would be for anyone getting a C-section, you would be getting a breathing tube. The main reasons why we don't jump to general anesthesia, what's the most obvious?
Well, you want to be awake for that baby to be put on you
Right.
or near you.
Right.
Or to hear that first cry.
But yeah, so the mom obviously is not participating in her birth if she's asleep, but also the dad or the partner cannot be there either.
That was actually one of my questions I was seeing in a thread. It was a lot of back and forth of, why can't my husband be in the room? And what is the rationale for why a spouse or a support person can't be in the room?
So as I was getting ready today, I was having a deep thought on this.
I bet you were.
And Because I always try to think, is this just the way things are, or could it really be done? How would that work? So being put to sleep, there's no role for a partner in that situation. It's really a medical procedure. We're putting a breathing tube in you. I was thinking about the time that my daughter had her ear tubes and adenoids out, and
Mm-hmm.
how, because she's a child, which sometimes they allow this, sometimes they don't, but they did allow me to hold her hand and walk her into the operating room and have her lie down on the bed and be with her. And they put the mask on her. And for kids, they often will put the children to sleep with gases through the mask. And then once they're totally asleep, then they put an IV in. She basically walked in there totally wide awake. And I watched her fall asleep just from breathing
Mm-hmm.
mask. And it was awful.
I was just gonna say,
I could cry thinking about
I'm
it.
sure. How hard was it for you to leave that room?
Awful. It was so hard. I mean, I can remember that moment so well. So as an adult, I don't think, as much as we're there for supporting and reducing anxiety, it doesn't make sense. You go to sleep very quickly. I mean,
Right.
you have to breathe some oxygen for a few minutes, and then you're going to get medications that work within seconds, and you're asleep. And then we have to put a breathing tube in you, do all these things that it's not appropriate for anyone else to be in the room who's not taking care of you medically.
But can I give you the pushback?
Yes.
But once the baby's delivered, I mean, I can see a side where if this is maybe a choice that's being made going in, that they know that this is their request and it's being met. Then once the baby is born, like, where's that transition of bringing the baby to the partner?
Okay. Well, let's think about how long it takes. So first of all, watching the actual birth is not something that
Right.
generally happens
I'm saying once the baby's
anyway.
been
But
delivered.
I was imagining, so if the partner is in the room after the patient's already asleep and maybe standing on a different side of the room or something, I'm really looking into the future here.
I'm sure you.
But that's then the partner watching the surgery itself, which is not what we're talking about. We're just talking about getting the baby to the partner sooner.
Right.
Okay. So there's already a delay, which we kind of talk about, of getting the baby to the mom
Mhm.
so it's like step one, right? So let's assume we're at a place where we're really trying to get either the mom or the dad, not the mom in this case, because the mom is asleep, the baby to the partner as soon as possible. Well, they are going to be taken to the warmer, whatever is their usual routine.
But does that baby need to be assessed for a longer period of time if the mom was put under general anesthesia?
Okay, good question. So we haven't talked about the pros and the cons yet.
Okay, jumping ahead, sorry.
No, that's a really good question. So maybe
Mhm.
one of the cons, the potential cons, is that the baby might be receiving some medications and be a little sleepier and require more time to wake up. But not always, and that's not a rule. That's just a possibility. It's kind of one of those things where, as the anesthesiologist, we have to communicate that to the pediatric team to say, this is general anesthesia. They might ask what kind of medications we gave the patients, but in general, there are two ways that we really work to reduce the amount of medications that the baby gets. So one is, let's say this is not a conversion to general anesthesia type situation. This is going in knowing you're having general anesthesia. Normally we give you this anesthesia, then you lay down, then we prep your belly, then we put up the drapes. It goes in that order. With general anesthesia, the way it usually works is you will lie down on the bed without anesthesia. Belly will be prepped and draped, and they will be basically ready to start the surgery. Then you get put to sleep. Then they start the surgery, so that the time between you being ready to have surgery and them starting the surgery is quite short. The other way is that the type of medications that we use, there's the IV medication, which is going to go away within a couple of minutes. After those IV medications wear off, you then have a breathing tube, which is giving you anesthesia gas, and that's what maintains the anesthesia. That's what keeps you asleep.
That is so interesting.
Yes.
I thought that was IV medication.
No, so you can do, it's a special type of anesthesia where it's IV only medication, but it's not the norm, basically. And it's better to do it with the gases because they are quicker to come off. If you get IV medications for a very long time, For example, patients in an ICU who are intubated for a long time will be on IV medications, and then it just takes forever for them to wear off. You can just wake up as soon as the surgery is done, as soon as it's time to wake up. With gases, they come off very quickly. You breathe them off, and then they're out of your system. If the time course is long enough from when they start the surgery to when the baby is delivered, such that some medications have gotten into your bloodstream and then crossed the placenta and gotten into the baby's bloodstream, if it's something like anesthesia gas, it's the baby's going to breathe it off so quickly. It doesn't generally cause much of a problem,
Okay, so can I ask you a question?
but it can.
Okay.
Yes.
So if you were having a regular surgery and a baby wasn't being delivered, would you
Mhm.
use anesthesia gases in the same way that you're using them for delivering a baby?
Yes.
Okay.
Yes. So baby might be chilling in the belly with you when you're
No, I just mean
Yes.
like, do you have a different kind of like
you mean
cocktail that you're giving to?
okay.
Okay, like if
Yes.
so I've gone under general anesthesia
Mhm.
before, and like I felt like the wake up was like the most in a way kind of like terrifying. Just like I felt so disoriented. Would you have that same response if you were having more anesthesia gas versus IV?
Most general anesthetics, whether it's for a C-section or not for a C-section, you are put to sleep with IV medications and you are kept to sleep with gases. We
Okay.
usually do we're more apt to give more IV medications when the person is not pregnant. So you're going to probably get some anxiety medication before you go in that you can get for a C-section, but we usually avoid it if we can, just one less medication.
Mm-hmm.
Pain medications are usually kind of given after the baby is delivered, especially longer acting pain medications. And it's really also the length of the surgery that's going to usually contribute to people feeling very disoriented when they wake up. So it sort of depends how long the surgery was. If the C-section, and with general anesthesia, sometimes things are moving a little bit quicker. It depends. But if it's a 45-minute surgery, that's a pretty short surgery when we're
Yeah.
comparing it to other types of surgery. It really just depends what additional medications you got, and you are going to get some additional medications after delivery to try to make sure that you wake up comfortable, especially if this is assuming that you don't have any spinal anesthesia of any kind on board, because then you need to treat your pain completely with IV pain medications. Whereas when you have a spinal or an epidural, another huge benefit to that is that we're able to put those narcotics in the spinal or epidural that help with pain after surgery. And like I said, so that's the morphine that causes the itchy nose, that one.
Yes.
So that one is so good because it helps with pain without, it lasts for so long and it's not really giving you all of the sedation that you would get if you had to get all of your pain medication via the IV.
Interesting.
And so that's kind of the only option if you don't have that spinal or epidural. So another con is the need for more IV pain medication generally with general anesthesia because they're not getting that spinal or epidural pain medication.
Right.
Other pros and cons?
Give them to
So
me.
the other cons are sort of, there might be an increased risk for. So these are not for sure. It's maybe when we're studying it, we're looking at it, it seems to be a trend towards this or that. Some of those are more breastfeeding difficulties, the needing more pain medication, a trend towards increased bleeding. And the only real reason for that potentially, other than the circumstances that maybe led up to general anesthesia, which might be emergent circumstances sometimes
Right.
and complications that go along with that, are that the gases that we give do relax the uterus a little bit. And so when you have a relaxed uterus after you deliver a baby, you want the uterus to contract nicely, right? And that helps reduce the bleeding afterwards. So if the uterus is a little bit more relaxed from the anesthesia gases, maybe that's contributing to like a little extra blood loss, but it's not really creating a postpartum hemorrhage. It's just a little bit more blood loss than if with Neuraxial. So these are all the reasons when everyone is saying, you know, this is the preferred way to do it. There are the reasons of usually the mom and the partner prefer it because they want to be there and awake, but also there are all these little things that we kind of have to keep in the back of our mind as providers to, you know, be extra mindful of the bleeding, for example. And the other risk with general anesthesia, which is very important, especially to me as the anesthesiologist, is we have to be able to put a breathing tube in after you're asleep. And we do that for all general anesthesia, but it's especially important to get that breathing tube in quickly for somebody who is pregnant because there's the risk of aspiration. So this is the reason we even talk about what you eat or drink prior to a C-section. It doesn't matter really if you're going to have a spinal or an epidural, but if you have general anesthesia, there's a risk of aspiration between the time of you being put to sleep and the breathing tube being in and securing your airway.
I'm so glad you answered that question because I feel like that is one of the most common questions. Like, does it really matter if I eat or drink? Or like, should I tell the doctors if I like maybe had something a little later than I should? And it's purely a safety concern.
Right. The reason why there's an argument, which I do completely understand, is okay, what are the chances of you needing general anesthesia? And they're low if you're not obviously requesting it or you know ahead of time that you have some reason that you need to have general anesthesia. And then what are the chances of aspiration even if you do have general anesthesia? And those risks are thankfully very low because we understand that this is a risk. And so we modify our anesthesia plan very specifically to avoid that problem. So back in the day, we talked about back to my grandmother's story.
Girl, I'm glad you weren't just going to say like 10 years ago because sometimes you do that, Jen.
I know.
Okay, back in the day, like in the 50s.
Back in the day.
Okay, that really is back in the day.
But they were, they didn't care what you ate in labor, but then they would drug them with gases. And then my grandmother woke up vomiting. I mean, she could have aspirated in that situation. And when also speaking of another thing we've been talking about recently, just the history of C-sections, why they were so risky, we didn't used to put the breathing tube in. So we would just have a mask and then people could vomit without a breathing tube in and aspirate. And if you aspirate, then okay, how bad is that? Well, it can be deadly, not necessarily, but it's pretty rare. I mean, it's something that I have seen never in a C-section patient, but I've seen it in my career, just in some other patients not having C-sections. But we know that inherently women who are pregnant are higher risk for that. If anyone has ever had acid reflux during pregnancy.
Oh, yes.
Right?
I had it so bad.
Me too.
I mean,
raging.
So bad. Yes.
So bad. And that is because the esophagus, so normally the bottom, you have your esophagus and it goes down to your stomach. And normally nothing should come from your stomach back into your esophagus. And one of the ways that happens is that there's a sphincter, something that's tight at the bottom of your esophagus, and it gets loose in pregnancy. So things can come up and cause that acid reflux and burning. You also have a big baby that's pushing on your stomach. So between those two things, you are more at risk for acid reflux, and then same with being at risk for aspiration as well. And we don't really, we tell you not to eat or drink for a certain amount of time, but we don't, unless we're looking at your stomach, we can't be really sure. This is the concern. So we need to be putting that breathing tube in quickly. The other problem with being pregnant is that sometimes we swell during pregnancy. And especially for patients who are preeclamptic, you can get a really swollen airway. And so that can make placing the breathing tube a little bit more difficult than in someone who isn't pregnant. So again, those are kind of rare issues to encounter, but it's something that as medical providers, we're thinking about and we're saying, okay, let's avoid these risks. And so that's another con or risk factor, which is a reason why the medical providers might try to talk you out of it if it is something that you are interested in being put to sleep for your C-section.
Can I ask you to give us maybe a story or a scenario in which somebody went in for a C-section not anticipating to go general anesthesia, and then something happened during the surgery that Like alerted
I
you to make it. I'm assuming you're the one making the call.
Yes.
Okay.
Yes. I will give you a scenario like that, but I'm going to start with a scenario where someone went in not thinking that they would need general anesthesia. And before the surgery even started, they might need general anesthesia. There's kind of two reasons. So, one would be that there is a contraindication to a spinal or an epidural. Those are rare, very rare. So the most common one is a bleeding disorder. So you might know that you have a bleeding disorder. If you do, then you may be followed by a hematologist. They may be the ones to say that this is, how likely are you to bleed? Because we don't want you bleeding into your spine if we put a needle anywhere in that area. That might be something you're aware of and have been worked up by a hematologist. But a really common thing in pregnancy is having low platelets. So low platelets can be just a part of pregnancy. Usually when you have something called gestational thrombocytopenia, that's just low platelets in pregnancy. They usually are not low enough that it prohibits us from safely placing a spinal or an epidural. With preeclampsia, that's a different story. You can have very low platelets, and in those cases, it can become unsafe to put a spinal or an epidural in that case. So that's why we always check a CBC, your platelet count, to make sure that they are not too low for anyone having a C-section, but definitely if you have preeclampsia, that's something that has to be followed closely. So that would be a scenario where if you came in, you're diagnosed with preeclampsia, they check your labs and they say your platelets are too low. We actually can't do a spinal or epidural. We have to put you to sleep. So HELP syndrome is a severe form of preeclampsia. And in those types of patients, a lot of times we have to end up doing general anesthesia. The other things are much more rare. So if you have an infection at the site of where we're going to put the epidural in, an infection in your spine, that would be a contraindication, not something I've encountered that I can think of. Also, if you have certain neurologic problems where you have increased pressure in your brain, you have a brain tumor, something very complicated, those type of things could also be a contraindication. Another thing would be, we've talked about the urgency of C-sections and how some are urgent and some are actually truly emergent running down the hall. And classically, we were taught if it's an emergency, then you put the patient to sleep. And that's now being seen as not quite the case anymore, because for an experienced anesthesiologist, you can put a spinal in just as fast as you can get a patient to sleep. That was a timing thing where they felt like if we need to get this baby out really quickly, general anesthesia is the way to go. We can do it so quickly. But in the right circumstances, with the right environment, at the right help, you can actually do a spinal just as quickly. So that's no longer a thing where we say, oh, just because this is super, super emergent, that this is the way to go.
Interesting. So how long would you say it would take you to put a spinal in versus having full general anesthesia and ready to go for the surgery?
So it all takes a few minutes. So for general anesthesia, it depends. First of all, we have talked about this before, but preparedness is so important. So I already have my breathing tube ready. I already have all the things that I need. I have my medications, but I have to draw up the medications. Some places the medications are pre-drawn. That's even better. You have to have your mask and your anesthesia machine, everything ready. So minutes. It should take minutes if you have everything prepared. For spinal anesthesia, same thing. If I have my supplies open and ready for me, it's 2 minutes and 2 minutes.
I think that's comforting to hear for patients or anyone who's listening and feeling a little bit concerned. Like, would it take 5 minutes, 10 minutes? We always talk about when you're feeling like something is a true emergency, every minute does really matter. And for the patient, like to know that you are already prepared for these scenarios. So this is not something that is new to an anesthesiologist.
Right. And that's why communication within the medical team is so important, because if I hear about usually some kind of emergency is diagnosed not in the operating room, it's diagnosed when the patient came in triage or the patient's in the labor room or whatever. And if I know quickly, I can then run to the OR, make sure I have everything completely ready for when that patient does roll into the room and do either thing very quickly.
You're amazing. Truly, though, I mean, like the amount of how ready and prepared you have to be at all times.
We don't just look at our phones.
No one thought you were looking at your phone, Jen.
That's kind of the reputation of the anesthesiologist, like
Oh, really?
doing crossword puzzles during surgeries, because it's either emergencies or we're chilling. And in
Right.
my case, that's why I like OB anesthesia. I was also just thinking about this the other day, is because I get very bored just sitting in an operating room with a patient who's asleep. But when I have an awake patient during a C-section,
You're
I
participating.
have a buddy.
You do?
I become a photographer. I become a doula. All the other things I like to do in life.
Calming the spouse.
Yeah, picking him off the floor. No, yeah, it's just like it's way more interesting to me. So the other question you said give an example of a patient who in
Right,
the
like the
middle
surgery,
of a
yeah.
surgery. So in that case, the assumption is that they did have a spinal or an epidural
Mhm.
and something has happened that now they need to be put to sleep. So there was Rachel's scenario, which is inadequate anesthesia. So, you hate to ever be in this situation. And, the question is always, why wasn't this recognized sooner or earlier or what happened? But in her case, it seems like they did not recognize from the very beginning that her anesthesia was not enough to make her comfortable and not feeling pain during surgery. And so the only answer to that is being put to sleep. She mentioned also that, if can the anesthesia wear off? And yes, usually not, but if the surgery is extra long or it took a lot of time to start the surgery after the anesthesia was initiated, something like that. Of course, it all has a time limit. That's the good news for most people because you don't want to be numb forever and you will be able to walk around again. But if you have a spinal anesthesia is great because it's this really dense block. It's easy to put in. It's quick, but it's a single shot. It's a single injection. So when it wears off, it wears off. If an epidural is in place and it's a working epidural and you do start to feel something during your surgery, well, that's a cue to then put more medication into the epidural. The other reasons besides the spinal wearing off and you not having an epidural in place to give more medications would be if there is a lot of extra bleeding. Sometimes we do make the decision to put the patient to sleep at that point if we're going to have to be doing some large resuscitation for many reasons. But I feel like at that point, if there is such a large complication, then you probably don't want to be awake for it anyway. And it's sort of a good safe move in that case as well.
Right. Something that I thought when I was reading about people asking about advice that they knew they were going to go in for a C-section, have general. One person chimed in and said, even though I knew I wasn't going to be awake for the surgery, I wanted music to be playing that was my choice so that the baby heard music that connected us together because I knew there was going to be a span of time before I could actually meet the baby. And I thought that was such great advice to give to another mom and how calming to like go into it and feel like, well, there's something there you're in control of. You're making a choice on like what your baby first
born to?
hears. Yeah.
That's very sweet.
And that's sweet.
I love that.
Maybe you can use that one next time. then.
Yeah. And I think, back to the partner being in the room. So we kind of discussed how partner's not really watching the surgery normally anyway. And whatever the usual routine is, we love the idea of course, baby being given to mom immediately. But in this scenario, the baby would be assessed
Mhm.
and probably, depending on the circumstances, obviously, if this is an emergency procedure because something was going wrong and that's why you had general anesthesia, that may be contributing to the baby needing any extra help at the beginning. But if it's just because you need general anesthesia, most of the time it's not going to have a huge effect on the baby. I wouldn't go crazy worrying about that. They'd watch the baby a little closer, see if the baby's going to take an extra minute or so to be more awake, get all of that out of their system. But as soon as the baby is stable, then the baby should be brought directly to dad, who would be waiting usually right outside of the operating room. So it's not super different as far as when the baby gets to meet mom or dad. In most normal situations where there is already that little bit of delay from delivery to mom or dad holding baby.
Something else that I thought was interesting in the chatter was that when they were waking up, they just felt like so disoriented in like their environment and how the baby being brought over to them right away was actually more overwhelming because they wanted to first like feel present before having that first moment of meeting the baby. And so I guess my question is like, and maybe there's just so many variables on this, but like normally how long would it take once you wake up to kind of like feel that grogginess and that like confusion kind of pass?
So this brings up for me a hospital policy, which
Okay.
may or may not be present in some hospitals, which is where will you wake up? And so if you do know you're going to have general anesthesia, this is a very, very important question to ask. So we always wake up patients, meaning they are awake enough to be breathing on their own. There is no breathing tube. We take the breathing tube out in the operating room, but most patients are quite asleep. You don't remember that part of it. You just sort of might remember waking up and we have an oxygen mask or something like that on your face. So that's when you're technically not under general anesthesia. I wouldn't call that awake. Then from there, you have to go to a recovery room. Normally, you go also to a recovery room after you have a C-section with any type of anesthesia. In some hospitals, you will go to a different recovery room than you would if you had your C-section under a spinal or an epidural. There's usually a labor and delivery recovery room very close to wherever the labor and delivery operating rooms are. At other hospitals, you may actually have to go to the recovery room for general patients, for not labor and delivery patients. And that, I don't love that.
Because does the baby get to stay with mom?
No.
Right. Okay.
No. So there's a lot of problems with that. One is that there's different type of nurses. So you'll have the regular PACU nurses who may or may not be as comfortable with dealing with the other things that have to happen during recovery, the fundal checks, monitoring bleeding. They may be more comfortable with taking care of a patient who's had general anesthesia because they see that a lot more than a labor and delivery recovery nurse would. But I don't think it's that different. It's just you wait for them to wake up. So in that case, if you have to recover in a different recovery room that is not on labor and delivery, then you wouldn't actually meet the baby until later. Now
So that would be a question you would want to ask.
Yes, and I have worked in places like this. And a lot of times I'm just thinking of certain scenarios where I've woken up mom in the operating room and the dad is with the baby in the labor and delivery recovery room. And mom is awake enough that, and I hope she liked this, and that makes me wonder, that we sort of tried to do a drive-by, like showing of the baby, like a quick hold, a quick snuggle before then going on to the main recovery room, knowing that she's now going to be there for a couple of hours without her baby and miss out on all of that. But it's interesting because maybe she's not fully awake. Is that something you want or don't want?
It's something to think about. It's also, I mean, I think back to like so many times our conversations with Kaylee Summers, and she said that she wished someone had just given her like reassurance and a reminder. So maybe if the mom doesn't necessarily recall that moment of the pass by, there's got to be that like energy felt of like their baby some close to them. And whether they recall it or not, I'm sure they're still making a difference. I'm sure that it has to be
It at least
connecting them in a
should be
way.
offered, yes.
Yes,
But I understand
yeah.
it can be disorienting. One thing, just speaking of being disoriented, as soon as I wake up a mom from general anesthesia, you went to sleep, you had your C-section, your baby's great,
Yeah.
you're great, you're just waking up now.
Right. That
But you
reassurance.
need to hear that because people
course.
and also people don't remember when you're waking up from general anesthesia. A lot of times, in other situations, I'm waking up a patient who had some other surgery and they ask you the same, like as I'm pushing them to the recovery room, they ask me the same question 5 times and I answer it 5 times. And finally, you just kind of say, well, I'll remind you again later, or you should ask this question again later because you're not going to remember asking it. And again,
that's all like a normal finding. That is not
Yes.
something, right?
Yes.
But I think that's good to know. Like that's a normal response after you're coming out of.
But you won't remember doing that if you did it.
Right. But if your partner keeps hearing you ask the same question, it could be comforting for them to know that like this is the process. Like this is,
It takes some time.
Yeah.
Yes. It takes some time, and it really depends on how much medication you needed during the surgery. But also, if you're waking up and having pain, are you needing more medications? That kind of the line starts to get blurred between, are we still getting rid of things that we got in the operating room medication wise, or is it now the medications that we're getting in recovery that are making us feel sedated or out of it? So that is actually when I'm thinking about if you're someone who wants general anesthesia, that is something to consider, is really the pain aspect of it. Now, if you cannot get a spinal or an epidural, then that is, you're left with the only option being the IV pain medications. Let's say you had general anesthesia for another reason. So either it was an emergency and that was the choice of your anesthesia provider, thinking they could put you to sleep quicker than they could do a spinal. Or if you're choosing general anesthesia for anxiety purposes or not wanting to be awake, which I am assuming that's why people might choose it, maybe a history of a prior traumatic C-section and they don't want to be awake for it, then you still can technically have a spinal. You can actually get that pain medication after your surgery. So I have.
Oh, that's interesting.
Yes. So it would not be the local anesthetic that makes you numb, but it would be, when I talked about this before our pain episode, we have the local anesthetic that actually makes you numb so that you can have surgery. But then at the same time, we put in the pain medication that helps with pain afterwards because we're doing.
You're going to have pain afterwards.
Yeah, and because it's like we're doing it all at once, you may as well. But you can actually do a spinal with just that pain medication. So all it does is help you with the pain for the first 24 hours. So I have offered that, and I have done that for patients who really, they don't want to be taking a lot of opioids, and we weren't able to do the spinal initially for a reason that isn't actually because it's contraindicated. You can still get that pain medication afterwards. Another thing that, speaking of pain, for someone who cannot get a spinal and cannot get that morphine in the spinal, is the tap block. The nerve blocks where they inject medication on either side of the incision. Those I don't do regularly for everybody because they're not proven to be any better than just the morphine alone. But if you don't have that morphine, the spinal morphine, then for any general anesthesia patient, I pretty much always do that for them.
So there's a lot of different ways that you can tailor this to a patient as well.
Right. Yeah.
That's what you're saying.
Yeah. There are lots of, I won't bore people too much with all the different choices that we could make during the anesthesia while the patients are asleep. But certainly afterwards for pain, that is a conversation to have with a provider ahead of time. If you know you're going to have general anesthesia, what are my options? So can you do any of these extra nerve blocks? Can you do a spinal afterwards with just the morphine? And then if not, most likely what they're going to reach for is the IV pain pump, where you can actually control how much IV pain medication you're giving yourself. And that's usually not needed because even with somebody who needs maybe a dose here or there of IV pain medication after a C-section, you're not getting so much that you need this pump where you're at the ready being able to keep giving yourself dose after dose after dose. It's just not necessary normally when you've had a spinal or an epidural.
Oh, you've given us a lot of information, Jen.
Yeah.
The last thing that I wanted to also mention, and this was kind of one of the back and forth conversations, is to decide if you want to breastfeed if you know you're going to go completely under, and who would maybe be the first person to help you start breastfeeding. Because one of the conversations mentioned that she hadn't really made a decision, and that she woke, or when she probably was already awake, but when she actually became lucid in the moment, that she had the baby already on her breast, and the nurse was just holding the baby there, and that felt very someone just made a decision for me, and that wasn't something she was.
That's not okay.
Right. But it's a good thing, I guess. Again, if you're making a decision like this, think about that as well. Do you want to wait for someone to try to initiate breastfeeding till you're like actually fully present in the moment?
There's always two sides of every coin. You know, it's
course.
the people who are brought to a different recovery room and can't see their baby for 2 hours. And then the person who wakes up with a baby on their breast. You know, the patient who gets general anesthesia when they don't really need it. The patient who's begging for general anesthesia and they tell you can't. It's just, it's very interesting. I think that at most hospitals, that is one of the first questions they ask you when you go into the hospital is, do you want to breastfeed? So I'm not sure if that answer was not heard or
communicated.
what.
I don't know.
So what this reminds me of is the whole pump and dump after anesthesia thing.
Oh,
that
yeah.
we've talked about before, that if you are awake enough to breastfeed, you could breastfeed,
Right.
but you should probably be awake.
Right. Well, I don't know. I'm just like going off of like, you told me to do the research on what's being chatted about. And this is one of the things that was chatted about. And then there was like 27 messages after that of being
What was
like,
everyone saying?
well, did you feel like uncomfortable? Were you happy that this happened? Like some people were
Was
like,
she happy or not?
well, she wasn't. But some people were like, you were so lucky that someone
Right.
tried to initiate that for you. So going back to
I mean,
your
I
point,
think you
like,
have to be awake.
right. I think it all goes back to like the medical team is truly trying to meet you in your wishes most of the time, we would hope, right? But there is still so much room of like, there's so many personal preferences that.
But I thought you were kind of going with that, the whole, are we worried about medications in the breast milk? Because sometimes you hear people being afraid to breastfeed because they just had general anesthesia.
Sure, it's part of the conversation as well.
Right?
I think it's both of those things are a part of the same conversation in some ways. Like
So, yeah.
maybe that was her concern was, you know, because I wasn't really awake, should I have even been breastfeeding? Like,
Yeah,
was
I
that
would say
safe to be
no.
doing that?
I would say no. You know, the amount of stories that we hear, I mean, it's good to hear them because sometimes you just can't believe
Totally.
that people have different types of experiences. Like our friend who's OB just didn't come for her C-section. I was just like, what? But
I mean, listen, I think that that's why having these conversations, like, and I was actually after reading all of this, I was like, I'm so glad that Jen is clarifying this because what ends up happening in social media is chatter can cause so much confusion.
right.
And think of when you're 20 messages in of different people commenting. I mean, I was getting ADD reading all the messages. I'm like, wait, what did that one person say again? You know, but it becomes a game of telephone a little bit. And that's the importance of why you clarifying this and saying that, you know, if this is something that you are electing, if you want to go under general anesthesia, here are the pros, here are the cons of why this can be done for you. And that's important to have that clarity.
Yeah. And you can breastfeed after general anesthesia for sure, after you're awake enough. And normally, I don't think that would be a very likely scenario where you wouldn't be awake and someone would be having the baby breastfeed before you are awake. But being awake is it's hard, you know, especially if you're groggy, you're in and out. But in general, like I said, the medications that we're using are very short acting. So you're breathing off that anesthesia gas very quickly. If you have gotten more IV medications in general, maybe that'll take a little bit longer. But within, 30 minutes, I would say most people, for the duration of surgery that a C-section normally is, that would probably be for sure you should be awake by 30 minutes. But many are quite awake as soon as they get to the recovery room, which, takes a couple of minutes to get there and transfer you onto the bed and whatnot.
I'm going to go totally flip us back to like the beginning of the
Okay.
conversation. If this was something that you were thinking about as a patient, when would you want to be having this conversation with your OB so that your OB is then having this conversation with the anesthesiologist who's going to be present that day for your surgery?
I think this is a really great reason to get an anesthesia consult during your pregnancy because, I mean, it's an anesthesia topic. And
Right.
so you really want to understand exactly what their policies are. And first of all, bring it up to your OB first, because one important thing is why. And you want to make sure that you've really talked out your reasoning. And we believe 100% in patient autonomy. This is sort of like the elective C-section situation. You probably have a reason, but in these scenarios, we're going to want to understand why. And because we want to make sure that you're fully informed when you're making these choices. So I feel like it's kind of similar where this happens more than we think, and you fully have the right to choose what type of anesthesia you want to have, whether it's a spinal epidural or being put to sleep. But they're going to want to have that conversation with you and talk through your specific risk factors like anything else. You may have a risk factor that makes general anesthesia a little less safe for you than somebody else. And so it would be very important to understand that. And maybe you were thinking, so I didn't mention this before, but one of the other reasons why we not be able to do a spinal epidural besides the bleeding disorder or these neurologic problems would be an anatomic problem. So let's say you've had a major surgery in your back. These are great reasons to get an anesthesia consult, to look at your imaging, figure out, can you do a spinal or an epidural? Why or why not? Is there some anatomic issue? And they might say, oh, we'll try. We're not really sure. And that might worry you. And then you might say, well, then I want general anesthesia. But then it's so important to talk to the anesthesiologist about these kind of intricate details of you specifically, of exactly what you're worried about and what really are the pros and cons to both scenarios. So I would talk about that as soon as you're thinking about it.
Would insurance cover a consult with you? I don't know.
To my knowledge, the anesthesia department doesn't get paid for consults now. But it's free.
Right. That's what I mean. So if somebody was like, I don't know if this is going to get covered or not.
There's no exchange of money.
Okay. No, but should they ask their insurance company if they should?
No, we do it for free.
Okay.
Yeah.
Okay.
Yeah.
But I feel like you don't really hear that word very often. Anesthesia and free together.
I mean, you really, I would ask, because that could be different at many different places.
Right.
I am pretty certain that everywhere I've worked, we do them, but we do not get reimbursed for them. But that doesn't mean we're like asking you to hand us a $20 bill or anything. It just means it's free.
I know that. I'm just trying to get into the head of all the
podcast is also free.
Just love giving out things for free. All this information today for free. Thank you so much.
Yes.
Do you have anything else that you want to add? I feel like you just brought a textbook.
On and on, but
well, we know you could. But you just brought like a textbook to life. All these questions, and I was actually very interested in it as well. And I think that this is a great topic that you did a deep dive on, so that people can clearly look at the chatter on different forums, see, like, you can get some great tips, like that mom who said, choose your own music. I thought that was so cute and sweet, but also be mindful of where you're getting your information from.
Yes, and be sure to ask your OB, try to get that anesthesia consult, but it's so good to know these specific questions. Where will I be recovering? Will my baby be with me in those hours after when I'm recovering from anesthesia? These little things that if you're just, even the anesthesiologist may not think to tell you, because it's sort of more about just the safety of the anesthesia itself. But these are pieces of the puzzle that you need to fully understand. What is my plan for pain afterwards? Do I need to worry more about pain afterwards if this is the type of anesthesia that I'm going to be getting? So those are all, I think, important things that we covered today.
I mean, I feel like it's our motto is knowledge is power, right?
Yes, it is.
And so thank you for making us all more knowledgeable today, Dr. Jen.
You're welcome.
I have to call you Dr. Jen today after all that information. The other thing I just want to wrap up with, are we ready to wrap up?
Yes.
So something I did for my sister who had a spinal surgery, actually, is I knew that because I had gone under before, and I knew I kind of woke up and was feeling like just so off, and I needed something to like pull me back in or just make me feel safe. And so I brought a lavender smelling salt for her. And to this day, she's like, it's one of the first things, like even when I smell lavender, she recognized like my voice was with the lavender, and it connected her back, and it made her feel grounded in that situation. So I think it could be a great thing for a partner to also, if you're making this decision and it's been approved and this is the delivery that you are having.
Or you've been told you have to do it.
Or you've been told that your partner could bring something that smells like, maybe it's a scent from home. Maybe it's that blanket that you brought because you didn't know this was going to be your path. Or if you think ahead and like, what is something that brings you calming sensations, a scent would be a nice thing to start waking up from anesthesia.
And it could be a part of those kind of, what do we call them? Kind of the alternative plans, the plans when things don't go to plans.
Yeah.
If God forbid we have to have general anesthesia, God forbid our baby has to go to the NICU, any of these things, how are we going to respond to make those situations, make sure we know what our wishes are in those scenarios. And so
Yeah.
that would be a great one to bring into the full picture.
Yes.
Full preparedness.
Full preparedness.
We do not leave you unprepared here.
No, not after today, Jen. Thank you so much.
So don't forget to feel even more prepared to download our free C-section guide. You can find it on our website, csxpodcast.com. I hope that it will bring lots of clarity to you and give you some ideas and things to think about. Please follow us on Instagram, the csxpodcast.com. We'll have some great new educational topics and things coming out for you there as well. And thank you so much for joining us. We will see you next week.